really key group of medications, especially for all you medical students in India following KMR advice.
That's right. We're talking about potassium-sparing diuretics.
Exactly. And think of this session as building a solid understanding, how they work, what they do, and importantly, the risks involved.
Yes. Our goal here in this deep dive is really clarity, understanding the mechanisms, and especially that big risk, hyperkalemia, high potassium. We'll follow the sequence from the KMR Advise document you have, just to keep it straightforward.
Perfect. So for our KMR Advise audience, let's remember there are broadly two main categories here. We'll kick things off with the aldosterone antagonists.
Good place to start. So drugs like spironolactone and eplerenone fall into this group.
Okay, so how do they work? Walk us through it.
Right. So imagine the drug is administered. It makes its way to the kidneys, specifically targeting the collecting duct cells. That's the main site of action.
And in the collecting duct,
Yeah.
what happens there?
Well, these drugs, they basically block the receptor for aldosterone. Aldosterone can't bind.
Okay, and for our KMR Advice students, just a quick reminder, aldosterone normally signals the kidney to hold on to sodium and water and get rid of potassium, right? Part of that whole REAS system.
Precisely. So normally aldosterone binds, and it tells the cell nucleus, hey, make more sodium channels. Those are the ENaC channels, epithelial sodium channels. And also make more of the sodium-potassium pumps, the nicokiapase.
Right. The machinery for moving ions.
Exactly. So if you block the aldosterone receptor with spironolactone or eplerenone, the cell doesn't get that signal as strongly.
Meaning fewer channels, fewer pumps.
Exactly. You get decreased expression, fewer of those ENaC channels on the cell surface facing the urine, and fewer pumps working.
Okay, so translate that into physiology for us. What's the result for sodium and potassium?
Well, with fewer sodium channels open, less sodium gets reabsorbed from the urine back into the body. And because sodium movement is linked to potassium secretion here, with less sodium reabsorption means less potassium gets secreted out into the urine. The body holds on to potassium.
Got it. So the clinical outcome is what, some mild diuresis maybe?
Yes, a mild increase in urine output, generally not as strong as, say, loop diuretics.
Yeah.
But the key effect, the reason they're called potassium-sparing,
Is that they cause potassium retention.
exactly. That's the crucial point for everyone following on KMR Advice.
Okay, so essential point for KMR Advise viewers. What are the big risks with this class?
The number one risk, without a doubt, is hyperkalemia. Too much potassium in the blood. This can be serious, potentially causing heart rhythm problems.
Really important to monitor. And wasn't there something specific about spironolactone?
Yes, good point. Spironolactone isn't perfectly selective, so it can also affect other steroid hormone receptors, sometimes leading to gynecomastia, which is breast tissue enlargement in men. Eplerenone is more selective, so that side effect is much less common.
Ah, a key difference for clinical choice. So for any patient on these aldosterone antagonists, what's the non-negotiable monitoring?
You absolutely must monitor their serum potassium levels regularly. And keep an eye on their kidney function too, as impaired renal function increases the risk of hyperkalemia.
Okay, makes sense. Let's shift gears for the KMR Advise audience. The second group, the ENaC blockers, amiloride and triamterene.
Right. Different mechanism here.
How so?
These drugs don't mess with the aldosterone receptor. Instead, they go straight to those ENaC channels we talked about.
The sodium channels in the collecting duct.
Yes, and they directly block them. Physically obstruct them, you could say.
So like putting a temporary plug in the channel?
That's a good way to think about it.
Yeah.
They stop sodium from moving through that from the urine into the cell.
Okay. And the consequence of that blockage?
Well, again, you reduce sodium reabsorption. And just like we saw before in this part of the kidney, less sodium reabsorption leads to less potassium secretion.
So the end result on fluid and potassium is pretty similar.
Pretty similar, yes.
Yep.
Mild diuresis and, crucially, potassium retention. They spare potassium just via a different route.
And the main risk for our future docs on KMR Advise using these ENaC blockers?
Again, it's hyperkalemia. Because they also make the body hold on to potassium, you have that significant risk of levels getting too high.
So the bottom line for amiloride and triamterene.
Monitor that potassium. Just like with the aldosterone antagonists, regular checks are essential.
Okay, great. Let's do a quick summary for everyone watching on KMR Advice. Potassium-sparing diuretics, they cause mild diuresis, but their defining feature is retaining potassium.
Correct. Aldosterone antagonists like spironolactone do it by blocking aldosterone's effects. ENaC blockers like amiloride do it by directly blocking sodium channels.
But the critical warning for both types
Is the risk of hyperkalemia. too much potassium. So careful monitoring is absolutely key. Remember that for your clinical practice, KMR advised viewers.
Absolutely. We really hope this breakdown has been helpful for all you medical students tuning into KMR Advise. If it was, please do share it, subscribe to KMR Advise, and, hit that notification bell for more deep dives like this.
And maybe something to think about after this. How would things like a patient's kidney health, maybe other drugs they're taking, how would that change how you think about using these diuretics? How might it influence the risks versus the benefits? Something to consider.